Good afternoon, gang. Although for you it could be morning or evening, but good day to you. Today we're going to talk about Unit 7, where we're going to talk about Staphylococcus aureus because it is probably the most problematic organism in the Staphylococcus group. And we're going to talk about some resistant strains, including MRSA, methicillin-resistant Staph aureus, VRSA, vanco-resistant Staph aureus, and finally VISA, vanco-intermediate Staph aureus. So let's get started. So Staphylococcus aureus is by far the most important pathogen among all of the Staphylococcus organisms. It can be isolated as part of the normal human flora, including normal flora of the skin, normal flora of the vagina, and to some degree normal respiratory flora, especially of the upper respiratory tract. About 20 to 40% of adults harbor this organism in their nares. It may not be MRSA, although they do screen for MRSA by swabbing the nares. And this organism will produce the coagulase enzyme. In fact, that's one way we can tell we're dealing with the Staphylococcus aureus by testing it for the coagulase enzyme. And if it's positive for coagulase, then you know you have a Staphylococcus aureus. Now, we as microbiologists have to determine if Staphylococcus aureus is normal flora or a pathogen, okay? There is a number of factors that can determine if Staphylococcus aureus is actually a pathogen. For example, the virulence of the strain. How aggressive is this particular organism, or how resistant is this organism? The size of the inoculum. We have to ask ourselves how much was the patient exposed to and how much grew versus the amount of normal flora. And then finally, we have to also weigh in the immune status of the host. If our patient is immunosuppressed, then Staphylococcus aureus could be a problem. There are several different conditions associated with the Staphylococcus aureus infection. For example, you can have an infection of the hair or skin, and those are called boils, furuncles, or carbuncles. A boil and a furuncle is a hair follicle infection, whereas a carbuncle is an infection of the deeper layer of the skin tissues. We could also have Staphylococcus aureus that causes impetigo, which is a very contagious skin pustule type of disease. Staphylococcus aureus can also cause scalded skin syndrome, which is produced by the epidermolytic toxins, and it causes skin damage and shedding of the skin. And you can see a picture of scalded skin syndrome in the upper right there in that image. The bottom right is an image of a patient that has impetigo. Staphylococcus aureus can cause pneumonia. It can cause bone infections such as osteomyelitis. It can also cause spreading invasive infections. Those are called metastatic infections. And also it can cause food poisoning or enterocolitis. And usually that's caused by enterotoxins A and D. And you can see this about 2 to 8 hours after eating a meal. Then what happens is if a person has a Staphylococcus aureus enterocolitis, they could have nausea, vomiting, diarrhea, and boiling food does not actually destroy the toxin, and the toxin can also survive refrigeration. There are a number of significant enzymes and toxins associated with Staphylococcus aureus. For example, we have the enterotoxins A through E. H and I are associated with food poisoning, but also A and D are also associated with food poisoning. Then we have TSST1, which is toxic shock syndrome toxin, and that is associated with toxic shock syndrome. Then we have the miscellaneous hemolysins. We've got the alpha hemolysin, beta hemolysin, and gamma hemolysin. An alpha hemolysin is a cytolytic toxin that destroys platelets. A beta hemolysin is a cytolytic toxin that destroys red cells. And a gamma hemolysin is a cytolytic toxin that destroys tissue cells and leukocytes. Coagulase and catalase enzymes are also enzymes associated with Staphylococcus aureus. And coagulase actually converts fibrinogen to fibrin, and you can see this in the coagulase test where we're using rabbit plasma as the reagent. Staphylococcus aureus is by far the most significant Staphylococcus pathogen. The single best reliable characteristic for Staphylococcus aureus is the coagulase test. What we're going to look for in the coagulase test is free clumping factor plus rabbit plasma equals a positive coagulase test, and that confirms that you have Staphylococcus aureus. There's also a latex agglutination kit for clumping factor, and it looks for bound coagulase. This is also a confirmatory test for Staphylococcus aureus. But as you can see in the picture there, we've got rabbit plasma in the 2 test tubes, and if the rabbit plasma remains liquid, then it's got to be some other Staphylococcus species. But if it clots like it does in that image on the bottom left, you can tell that your bug produces coagulase enzyme, which means that you have Staphylococcus aureus. Staphylococcus aureus is one of those organisms that you should be able to recognize by the end of micro 1 and micro 2. On 5% sheep's blood agar, they are usually gamma or beta hemolytic. They're often gray, white, or even pale yellow. They're not going to be bright yellow though, but they could be pale yellow like butter. Like I said, they're about 50% of the time beta hemolytic, and the other 50% of the time they are gamma hemolytic. And sometimes you can see what's known as a double zone of hemolysis, and you can see that in the image on the right. You can see that we have the colonies of Staphylococcus aureus, and then we have a strong zone of beta hemolysis right up next to the colony, and then further out away from that inner zone, we have an outer zone of beta hemolysis, and you can see that with only a couple different organisms. Staphylococcus aureus is one of them. So MRSA is methicillin-resistant Staphylococcus aureus. Not all Staph aureus are MRSA, but a good 50% of them are. Now, back in the day, Staphylococcus aureus used to be sensitive to penicillin. Now, 80% of regular Staph aureus are resistant to penicillin. Methicillin was developed to combat strains of penicillin-resistant Staph aureus. Many strains of Staph aureus are now resistant to methicillin, and these, of course, are the MRSA varieties. Methicillin is the same thing as oxacillin, so if you hear of an organism being resistant to oxacillin, it means that it's also resistant to methicillin. So if you have an MRSA, vancomycin or IV vancomycin can be used to treat MRSA, but this should only be a last resort. There's actually other drugs that can be used to treat MRSA, such as rifampin and Bactrim. Imipenem is also a good drug to use. There are 2 types of MRSA that can be isolated. One is called community-acquired MRSA, and one is called hospital-acquired MRSA. About 14% of all hospital patients will develop a nosocomial infection of MRSA. Up to 41% of MRSAs in a community acquired, according to Yale University study from a few years ago, are MRSA. They can be a primary cause of skin infections, and they're not associated with any one risk factor or as once thought. One way that you can prevent the spread of MRSA in a community is to avoid sharing things like towels and razors. Okay. Like I said, the hospital-acquired MRSA can happen about 14% of the time. Staph aureus can be placed on a Mueller-Hinton agar with 6 micrograms per mil of oxacillin, and if our organism grows in the presence of 6 milligrams of oxacillin, then that means that you have Staphylococcus aureus MRSA. We can also do another test called the PBP2A test, which stands for penicillin binding protein. It determines the presence of what's known as the MEK-A gene on some bacteria, especially MRSA. The MEK-A gene interferes with the beta-lactam drugs and would cause a isolate of Staphylococcus aureus to actually be MRSA. VISA stands for vancomycin intermediate Staphylococcus aureus. Now, that could be a problem because vancomycin is typically used to treat people that have difficult cases of MRSA. And if you have a difficult case of MRSA and you cannot treat with vanco, then what do we treat with? So that could be a problem. Theoretically, up to 2.7% of all MRSAs are actually VISAs. There was no confirmed cases of VISA in the United States. However, there have been cases confirmed in Taiwan. VISA and VRSA are usually seen in patients already immunosuppressed with things like diabetes or kidney disease. So far, all VISAs have been able to be treated by some sort of approved FDA drug. Now, VRSA stands for vancomycin-resistant Staphylococcus aureus, and there's been 14 total cases in the United States to date. VRSA was first seen in 2002 in Michigan, Pennsylvania, and New York. There was a four-fold increase in vanco-resistance than regular Staphylococcus aureus. Laboratories should always screen for VRSA by putting your isolate on a brain-heart infusion auger that has the addition of 6 micrograms per mil of vancomycin. If your organism grows in the presence of 6 micrograms of vancomycin, then it must be a VRSA. The cost of antibiotic resistance to the U.S. budget is about $5 billion a year. Anytime you have an aerobic gram-positive cocci, we always want to do the catalase test to make sure that we're dealing with the Staphylococcus. Remember, Staphylococcus is always positive for catalase. It's not a bad idea to do a gram stain also. The catalase test will determine if we are dealing with the Staphylococcus, which are catalase positive, or a Streptococcus, which is catalase negative. All Staph and Micrococcus are catalase positive, while Streptococcus are catalase negative. So catalase is a good way to determine if you're dealing with a Staphylococcus versus a Streptococcus. The catalase test is one of the first tests that we can do on an isolate to determine if we are dealing with a Staphylococcus or a Streptococcus. Generally, all tests performed in the microbiology lab are performed on the least selective and differential freshest plates. Often the plates are less than 24 hours of growth on them. Be cautious when doing the catalase test not to get chunks of blood agar in the reagent because you'll get false positives due to the peroxidase in blood cells. Now, the catalase test, the principle is this. Some bacteria synthesize the enzyme catalase. When 3% hydrogen peroxide is hydrolyzed, gaseous oxygen is released in the form of bubbles. So in other words, if you smear your colony isolate on a slide and then you add a drop of catalase, if it bubbles, that means that you're dealing with the Staphylococcus. It could mean that you're dealing with a Neisseria, but we have yet to talk about that. Okay, so the procedure is you take a colony of your organism, you smear it on a glass slide, and then you add 1 free-falling drop of H2O2 and look for bubbling. Any bubbling that occurs within 20 seconds is a positive test for catalase. And again, Staphylococcus are positive for catalase, while Streptococcus are negative. Anytime you're dealing with a gram-positive cocci that's catalase positive, it's probably going to be a Staphylococcus. Anytime where you're dealing with an aerobic gram-positive cocci that are negative for catalase, you're probably dealing with the Streptococcus. Once you've determined that you're dealing with a Staphylococcus, you can set up what's known as the coagulase test tube test. The coagulase test tube test determines if we're dealing with Staphylococcus aureus versus some other form of Staphylococcus. Free coagulase will activate fibrinogen in plasma to form a fibrin clot. So the procedure is to bring the frozen reagent to room temperature, and that reagent is rabbit plasma. Once it has reached room temperature, we add our organism to a tube of rabbit plasma and we put it in the incubator. We wait 2 to 24 hours. So in other words, we check it at 2 hours and we look for a clot, and if it hasn't clotted within 2 hours, then we leave it for 24 hours. But we do want to check it after 24 hours because beyond 24 hours, they can actually revert back to negative. We want to observe the formation of a clot. If we have a clot in our 500 microliter aliquot of thawed rabbit plasma, then we in fact have a Staphylococcus aureus. Anytime you have a Staphylococcus species, we always need to do either the coagulase tube test or the latex agglutination test for clumping factor. We always have to prove that our Staphylococcus is or is not a Staphylococcus aureus. Okay? A positive coag tube test indicates that we have Staphylococcus aureus. A negative coag tube test means that we have a coag negative Staphylococcus. So Staphylococcus epidermidis or Staphylococcus saprophyticus are 2 of our coag negative staphs, and they would be coagulase tube test negative. We also have what's known as a slide agglutination test for clumping factor. The principle is this. Bound coagulase is also known as clumping factor. This test will indicate if the staph species isolated is Staphylococcus aureus versus another species of Staphylococcus. This test is not as sensitive as the tube test but may be adequate. The procedure is this. What we do is we warm up our test kit, and that test kit includes a suspension of latex particles. Once those latex particles are warmed up, we can actually dispense a drop of that test latex onto a black test card. In that drop, we can mix several colonies of the organism and then rotate the test card for 30 seconds to a minute, and we look for agglutination. If agglutination occurs, then we have Staphylococcus aureus. So this can be used instead of the coag tube test. We can use instead the slide agglutination test. So here's an image of the slide agglutination test where we add a drop of our latex suspension to a test circle, then we smash our bug up in it and mix our bug around in the latex suspension, and then we hand rotate for 30 seconds to a minute, and we look for clumping. So you can see in well 1 it's very smooth, so that's an example of a coag negative staph, and then in well 2 you can see several clumps. That's an example of Staphylococcus aureus. All right, let's go ahead and name the reagent. If you have the catalase test, what's the name of the reagent? The reagent would be 3% H2O2. If you're dealing with the A disc, what does the A disc stand for? The A disc stands for basotracin disc, and the basotracin disc is one that we can use to determine if we have a Staphylococcus species versus a Micrococcus species. The P disc is a disc that is used to determine if we have a Streptococcus pneumoniae. This is also known as the optochin disc, or ethyl hydrocuprine hydrochloride. Coagulase, the name of the reagent is rabbit plasma. Microdase, the name of the reagent is 6% tetramethyl P phenylenediamine dihydrochloride. Do you have to spell that? No, you don't. You just have to be able to recognize it. Just understand that the microdase test is a 6% solution as opposed to a 1% solution. When we start talking about the oxidase test later in further units, we'll talk about 1% tetramethyl P phenylenediamine. All right, let's go ahead and take a look at some images here. So if you have gram-positive cocci that are in a chain, what you have is something that is probably a streptococcus. Here's another example of streptococcus where you have gram-positive cocci that are in a chain. And here's some more streptococcus. This could actually be Streptococcus pneumoniae. You can actually see kind of by those white cells, those red dots are actually white cells, and you can see that some of the gram-positive cocci are in pairs and they are lancet shaped. And this is pretty typical of Streptococcus pneumoniae. And then here's a nice example of Staphylococcus where you can see large gram-positive cocci that are in clusters. And then this is meant to fool you. This is actually not Streptococcus or Staphylococcus. This is a picture of budding yeast. And you can see that they're kind of oval shape, and the mother cells often have little buds. And the arrows are pointing to the little buds. It actually looks like the bottom of your shoe or a little shoe print. And that's it for Unit 7. Hope you enjoyed it.